Hi and welcome. I'm Dr. Susan Ivey from the School of Public Health and family physician by training and new to oral health, thanks to Dr. Karen Sokol-Gutierrez about 4 years ago. She's kind of a vortex that brings a lot of people in. So I thought I would just say, show of hands, how many of you are in this room because of Karen? A lot of us. So I'm here to introduce our first speaker, but just to also recognize and thank Karen for this wonderful set of speakers we're going to listen to. Our first keynote speaker is Dr. Saskia Estupian. She's a public health specialist from PAHO with worldwide experience in the Americas, Africa, Asia, and Europe in developing regional oral health strategies. She's implemented national programs and conceived, led, and implemented a number of major innovations in both research and cost-effective oral health prevention programs to improve oral health and improve access to health services. This includes work on salt fluoridation, atraumatic restorative treatment, and use of cost-effectiveness analysis to support oral health policies. I think that's one of the challenges that I've seen in working in Vietnam is not just to have evidence-based programs, but to be able to provide information that shows that these can be sustainable in middle and low-income countries. She completed advanced training in pediatric dentistry and public health at UCLA, one of our nemesis, and is, has been the coordinator of regional oral health program at PAHO for 22 years. Most interesting in her background to me is that she's on the master's track and field team, runs 80-meter hurdles and 300-meter hurdles, and I thought to myself, the oral health, overall health connection is more like the 300 meters than the 80 meters in my experience. She was a national track champion in her native country of Ecuador when she was younger, and is writing a book about her life called Hurdling Through Life Without Fear, which again was very reminiscent to me of a metaphor for what we're doing in oral health and bringing that into the pack, so to speak, of health and healthcare services. So welcome, Dr. Estupian.
Good morning, everybody. It's such a pleasure to be here. This is my first time here at the University of California, Berkeley. I've spent many times in UC system in Los Angeles, so it's kind of nice to be here, to be back. I want to thank, first of all, Karen Sokol-Gutierrez and Dr. John Greenspan for inviting me to this great symposium. It is a great honor, and on behalf of the Pan American Health Organization, World Health Organization, we congratulate University of Berkeley and UC San Francisco for launching this symposium. And during my talk, I hope I can cover a range of issues and talk a little bit about the complexity of the global health landscape ahead of us and the importance of aligning oral health with general health and with NCDs. Before we can enter into the real talk, and when Karen gave me a title, the first title was What We Know, What We Don't Know, and the Challenges Ahead. So I started preparing for that, and I was excited. And then within 2 weeks, a new, program came. It was alignment, and I thought, ooh, that sounds better. So to be able to talk about alignment, I thought first let's really look at what's alignment really. So I went into the dictionary, several of them, and there are many definitions, but the one that I kind of felt like will fit this talk was about straight or incorrect place, and the second definition was about activities or systems so that they match or fit well together. So I thought alignment, but to be aligned, there is a second word that is very key, and I hope through the presentation you keep these two words in mind because they are key to our work. And the second word is integration, which comes from the Latin integer, and that means being part of a whole, or generally means combining parts so that they all work together and they are part of a whole. Examples of good alignment, and I start thinking, okay, we always hear this word integration of primary health care into the systems, but what does that really mean? And I thought a good example was our solar system. Our solar system has alignments of the planets, but also all these planets are integrated and they work together. And the other example, I have an engineer who works for me in soil fluoridation at Pago, and he says, Saskia, I think cars. Car is a good example because in cars you have the alignment of those wheels that are integrated into the car. And if the wheels are not aligned, then, the car is not going to run well. So I thought, okay, that sounds good. So to bring in those two words into the talk, first we have to know what we have out there. And I'll go briefly through the global burden of disease in general, and then I will move it to oral health. We know that we have improved global burden of disease. Measles deaths have been cut by 24%. The world is getting heavier. We have almost 3 million people dying each year as a result of being either overweight or obese. And the Americas, our region, has the highest percentage of obesity in the world. We also know that because of the efforts in public health and the work of universities and other actors, we are improving maternal and child deaths. In the past year, we have improved by almost 50%. We had about more than 500,000 in 1990s, and now we have about 290,000 in 2010. And also, as we develop public health programs, we learn about cost, because cost is critical, and I think Pam said about sustainability. If we don't know how much it costs, it will be very difficult to convince policymakers to invest in health. So what we have now is that investing in health varies among the regions in the world. For example, a country like Eritrea will spend $11 per person a year, as opposed to Luxembourg that spends $8,000 per person a year. The average for low income is about $25 per person per year. In the Americas, almost every indicator has improved. Mortality rates have been declined by 25%. We're living longer, by about 6 years, about 68 years of age for Central America as compared to almost 78 for North America. The Americas has eliminated polio. Our vaccination coverage has surpassed 80%, and perinatal deaths have declined 35%. And the decay means filled teeth indicator has declined in almost every country in the region of the Americas. Trends in child health. Children our mortality rates continue to decrease, but morbidity is also decreasing for many medical conditions which were different 20 years ago. Because we collect more data, we're able to look at disparities in health outcomes, and we know those are increasing. And then we have emergence of new morbidities and concerns, like the rise of obesity, ADHD, mental health, and some others. Our children are also exposed to new risks, and they are changing. We have the nutrition transition. Our families are squeezed. Our children are living in a hurry environment, and also very toxic. Obesity. Obesity is a major problem in the Americas. In Mexico, it is the biggest health problem. Worldwide, Mexico has the highest obesity rates for children, and is the second for adults. And their 2012 national survey, a nutrition survey, report that nearly 5.7 million children in Mexico are overweight and obese. And Mexico spends 7% of total health expenditures in obesity. In Mexico, the obesity curve tripled in 1 decade. So, here what we want to see is the standardized prevalence of overweight. This is a chart from WHO for adults. And what we can see really that the Americas have the highest level, and then we have Europe next. Sorry about that. Oops. We have Europe, and then for PAHO, for the Pan American Health Organization, obesity, it's a big priority, and PAHO is developing an action plan for governments to tackle obesity in children and adolescents. And Karen should be pleased to hear that. Here, this is just briefly, this is from the Lancet, and it is a comparative, it's the burden of disease, a comparative assessment of disease and injuries. And we can see that 15 out of the 20 factors associated, risk factors are associated to nutrition. And this goes from, low intake of calories for maternal and child health, diets that are not appropriate, diets that lack vegetables, and increasing of fats in diets. But the point here that I want to make is that 15 out of 20 are related to nutrition. Next. This new plan that PAHO is developed will promote maternal and child nutrition, and will tackle children, very young children, and will also tackle to improve school nutrition. And physical activity, it plans to help countries to regulate the intake of food that are high in sugar, fats, and sodium. But this plan, as opposed to other plans, will try to work together with ministries of health, ministries of education, and ministries of physical activity. And it will do some surveillance, and include surveillance. WHO this month announced the new guidelines of sugar intake. The previous guidelines of sugar intake were that it was okay to have 10% of your energy for that day attributed to sugars, to free sugars. But now the new guidelines, and they not only are to tackle nutrition, but also dental caries. And the new guidelines are recommending about 25 grams per day, which is about 16 spoons of free sugars and about 5% of total energy intake. Now, this is going to be a big challenge because what they're going to be tackling, obviously, is beverages. It is our knowledge, and this comes from the IOM, that they found that soft drinks contributed in the United States a higher proportion of daily energy intake for overweight than for non-overweight children and adolescents. Now, sugars are important to dental caries because sugar causes is a risk factor for dental caries. Let's look at what's happening with dental caries in the world. And we're going to use the indicator DMFT. And for those who are not familiar, this indicator it's used at 12 years of age. And that's just to give us an idea of the trends of where we're going with dental caries and with policy. So what we have for the African region, the indicator in 2004 was 1.15 at age 12, and now you can see an increase, 1.19 at age in 2011. For the Americas, we can see a trend that it's lower, and we're going to talk a little bit more about that in detail, 2.76 to 2.35. Globally, the indicator has pretty much stayed the same, but we have to be careful about how we look at this data because it's looking at the big picture, but it's not really giving us the picture at a country level, at a state level, or at a community level. Those are just average data. In the Americas, we have collected 56 national oral health surveys, and this data is being collected jointly with PAHO and with the ministries of health and their dental programs. And we can definitely see a marked decline between 35 to 85% in the prevalence of dental caries. And this is mostly attributed to cost-effective interventions using fluoride as the main vehicle. And the fluoride, whether it's in the salt, in the water, or even in milk, as we have in Chile. But the point here that I want to make is that I don't know how to use this little arrow without. Okay. If you look at the graph in 1980, a DMFT more than 5 will look like the teeth here down below, right here. So if you have more than 5 decayed teeth, this is kind of what your mouth was going to look like. In the 80s, 17 countries had an average of DMFT like the one below. The policies were put forward to implement fluoridation programs in the 1980s to 2000, and mostly through salt fluoridation and also some improvement in health services. And we can already begin looking at this change of the epidemiological pattern in which the DMFT now, you don't see that rampant caries and untreated, but now you begin seeing the treatment of dental caries. Oops, I'm going to run through this. And then, obviously, DMFT in 2012 has improved by 34 countries had improved DMFT. We're going to have to run through this. We have shift from emergency to community programs. We have better understanding of prevention. And obviously, the oral health surveys are reporting an improvement. Most countries in the Americas have oral health plans, and they're focused on vulnerable groups. Sometimes they're part of primary health care programs, but they're not aligned with other programs. Early childhood caries, it is very high in the Americas, but we don't have exact data because we don't conduct data on children under 6 years old. But we know it's a problem, and also in the United States, for example, the surgery, general surgery using general anesthesia has increased due to early childhood caries. HPV and oral cancer is also a problem, and there is more evidence now that this cancer is associated, and it will increase in the next few years. It will even surpass cervical cancer in the United States. Clear-lifting palate is also a problem. In Africa, dental caries is less common because they haven't been exposed yet to nutrition with high levels of sugar and processed foods. And NOMA, it's a debilitating, disease. It's a public health problem in Africa, and ministries of health have made a commitment to tackle NOMA. There is an association of poor nutrition, poor environmental conditions, chronic malnutrition, and exposure to measles and malaria. Those are risk factors for NOMA. Well, what we understand what's happening with oral health, there is a parallel event that happened at the United Nations in 2012, and that is the high-level meeting where heads of state met to tackle non-communicable diseases. There has been 20 World Summits by the United Nations, and only one previous to the non-communicable disease, which was HIV/AIDS. So non-communicable disease was put on the global public health agenda, and the World Health Organization was given the mandate to come up with plans so then governments can tackle this NCD epidemic around the world. This declaration for the first time included renal, oral, and eye diseases. And why is this important? Because for the first time we see oral health in a major United Nations political declaration. What are NCDs? There are 4 common NCDs: cardiovascular disease, cancer, diabetes, and chronic respiratory diseases. And they contribute to the largest mortality in developing countries and in transition. They are projected to increase by 15% globally between 2010 and 2020. And this greatest increase will be in Africa, Eastern Mediterranean, Southeast Asia, where they will increase by 20%. They are preventable. There are 4 risk factors: tobacco, unhealthy diet, physical inactivity, and alcohol. And you can see from this that Homer will have, I say, all of them, and will develop all the major NCDs, while Marge, who exercises and takes care of her diet, will maybe perhaps not develop so many. Why are they important? Because there is a socioeconomic impact. 250 million out of the almost 900 million suffer from NCDs in the Americas. In 2015, this has increased, and 39% are females. Why is it important to oral health? Because the burden of major oral diseases and conditions is high, because oral health is part of general health, and we share the same risk factors than other chronic diseases. And we need to be integrated and aligned with the non-communicable disease families. Common risk factor approach has been one of our major pillars right now at the oral health program at PAHO, which is connecting the links. So if you look at the major oral diseases like periodontal diseases, oral cancer, and caries, and if you look at the general diseases of NCDs like cardiovascular disease, cancer, diabetes, and respiratory, we share 3 out of the 4 common risk factors, and that is tobacco, alcohol, and poor diet. So oral health and cardiovascular diseases, well, the relationship is that oral bacteria enters the bloodstream, it attaches to fatty plaque in the coronary arteries, and contributes to clot formation. Periodontal disease may activate these pathways to systemic inflammation, which then may contribute to inflammation of blood vessels. Oral health and diabetes, well, diabetes is one of the biggest growing problems in Latin America. 6% of adult population have it, and more than 60 million people suffer from diabetes. The relationship is increased prevalence of gum disease among those with diabetes. People with diabetes are more susceptible to serious periodontal disease, and also it contributes to affect blood glucose control and to the progression of diabetes. They are more susceptible to bacterial infection and have decreased ability to fight bacteria and invade the soft tissue. And oral cancer, and with oral cancer, we want to make sure that it is the risk factors like tobacco, alcohol, but now we have the HPV oral cancer associated. So, remember those 2 words, integration and alignment. For PAHO, though, that's key because it forces us to do a shift of paradigms. We have to switch gears. We have work, we make good gains, but we have work in our own little corner, isolated. Sometimes we say, yes, we're integrated, but truly at the end of the day, we don't see that happening faster than we would like. So we have proposed that we need to be integrated and aligned with primary healthcare systems in 2 ways. On the control prevention side, we must empower individuals to modify those risk factors for NCDs, the 3 that we have in common, and stimulate action to improve oral health. By the way, this is my daughter on the left and my son on the right side when they were little. On the control prevention side, besides empowering the community, the individual, ourselves, we also need to strengthen the capacity of oral health and healthcare professionals for prevention and control of risk factors for NCDs through oral health screening, early detection, referral services, and health promotion approaches. That's on the control side. On the treatment side, we're working so we can empower oral health professionals, that's us, the dentists, to take action to prevent risk factors for NCDs. So we just not focus on the dental caries, the periodontal disease, or the nutrition, but we're looking more on that integration and alignment. The risk factor approach is critical. Currently, what we see really that we're looking at populations, a risk population really are adults and seniors. In other words, they already got those, the risk factors, the diseases, the cardiovascular disease, the diabetes, and the cancer. And our approach is, let's treat, which is more expensive. So what we're proposing and what we're working is, in the future, our risk population has to start with prenatal health care and infants. And I know you like that. And our adolescent and young adults. In other words, prevention, but go back to prenatal health care, that mother that is pregnant. That's where we need to be aligned and integrated. PAHO, to further improve oral health in the Americas, launched a Caries community-free initiative, and that was launched in 2008 in Mexico City. And during the launching of this, and during the progress of communities-free Caries, we had the developments of the high-level meeting at the United Nations. So we took those two together, the Caries-free communities and the high-level meeting, and began working with new approaches to oral health. We have developed modules because one of our challenges was we wanted to work with community health workers, and when we went to train them, what we found is that we didn't have the materials really. What are we going to tell them about oral health? But we didn't have this comprehensive approach about risk factors. Why you need to treat, why you need to approach a pregnant woman. We needed that material. We needed to develop that. What's the language? What's the message we want to tell healthcare providers about oral health? Is it about caries? It is about periodontal disease? No, it's about general health. Because if you take a pregnant woman or a small child and make them understand and empower them that it is about general health, it's not about just, looking at this small cavity with teeth, but there is a relationship to nutrition. There is a relationship with cardiovascular diseases. So these modules have been developed. For example, we have a module for teenagers that we're empowering teenagers and also community health workers. And we're oral health people, but we're talking about, oral sex, HPV, which is something that we didn't do that before. The relation of HPV, what happens if, and we're also working right now, we're going to have a big meeting about the importance of HPV and trying to see if we can also contribute to working with the vaccine department at PAHO so we can just be integrated in their policy. We don't have enough research that says that the vaccine is going to help, reducing cancer in the mouth due to HPV. We don't have that information, but we do know that cancer related to the HPV is increasing, and we also know that our teenagers are exposed to that cancer. So this is totally different than what we used to. So that's the change of paradigm. This common risk factor approach, a broader definition of oral health based on health prevention, promotion, and disease surveillance. We have activities carried out in several countries. We have a multi-country project right now. The countries that we're targeting through Train the Trainer workshops are Mexico, Guatemala, Colombia, Ecuador, Peru, and Jamaica. And this we hope to scale up. And this is just this is from the modules in which you can see we're approaching. We're tackling artificial juice, soft and energy drinks, sweets, diet, junk food, tobacco, alcohol, and we're even talking about the need to exercise, which is a very different approach than what we used to. This is an example of Communities Free of Caries initiative in Subcentro de Salud in Chuga, Ecuador. We didn't see this. 20 years ago, we couldn't see healthcare promotores de salud or healthcare providers taking a look at the children's mouth. These are infants, so it's happening. It may not be as fast as we would like, but we see this shift of paradigm. One of the things that we're currently doing with one of the universities, and I think that's where a university can play such a major role, is Universidad Cayetano Heredia. We're going to get ready to do a research to see if we can put fluoride varnishes, application of fluoride varnishes, but healthcare providers. So the nurse, when the child is going to be vaccinated, you know, there's several vaccines, 6 months, 12 months, 8 months. So each time that child gets vaccinated, an application of fluoride varnishes will be done. Not only that, but parallel to that, the mother will be educated. And this is what we're talking about. So remember that when we talk about integration, alignment, guess what? This is a very good example of aligning oral health, because we are being aligned with a vaccine schedule. And at the same time, we're being integrated. So that's what I want you to take with you. How do we integrate? How do we align? It's not going to be by just oral health, but you got to look at the big picture. Where is it that I can fit in? So I want to share this with you because this is very exciting, because at the end of the day, we can say we are aligned with, you know, the oral health, the vaccine schedule. We're going to have a nurse. She vaccinates the child, and she will ask the mother at the end of the day, has the child gotten fluoride varnishes? No, not yet. Oh, we need to make sure that that child gets the fluoride varnishes. Whether the fluoride varnishes is effective or not, because we're not measuring the effectiveness. What we're more interested is in transferring, empowering the community, the individual, so they understand as early as this age that oral health is important. So the education will begin here. Challenges. We got big challenges. Alignment and integration. Can we do it? Can the dental profession help modify risk factors for NCDs and stimulate action to improve oral health? Unless we're aligned and integrated, no, we're not going to be able to do it. The sustainability. We need to strengthen competencies using this multidisciplinary team approach, and we must empower oral healthcare professionals to take action to prevent risk for NCDs. We want to hear dentists talking about tobacco, alcohol, diet. We want to hear nutritionists talking about oral health in younger population, in adult population. That has to be a very dual message. So unless that's done, we won't be able to align or integrate, and we want to empower communities. What's ahead of us? The challenge, the agenda, us being integrated with this NCD's global agenda. Oral health has been recognized already in that high-level meeting as being part of that NCD's family. Prevention, promotion needs to be aligned and integrated into primary healthcare policies, planning and implementation and evaluation process. So if you go out there to the community, remember this. Don't just stay on that little space of yours that is oral health, but look at how you can be integrated, because if you're integrated and aligned, your chances of being sustainable are much greater. The workforce for oral health can strengthen partnerships and build networks to achieve the NCD's global agenda. We have changing patterns of child morbidity. We're going to have children that are going to have several comorbidities like asthma, obesity, ADHD, diabetes type 1. They're hairy children. We got mental disorders. This is something that a few months ago I was at NIH at the symposium, and this slide was very, really impressive to me. Alfred Marshall, in his book of Principles of Economics, made this remark: the greatest capital that you can invest is in human capital, and of that, the most important component is the mother. And then Joseph Heckman, Nobel laureate, He is known for his well-empirical research in labor economics, particularly related to the efficacy investment of early childhood education programs. And he said it very clear, if you have to choose the best return to your unit dollar invested, it will be the mother and the young child. So, where are we 50 years from today? And I thought, I have to think of my children. Anik on the left and Jonathan on the right. And their children. Their life will continue to improve, but I wonder, when my grandchildren or great-grandchildren will be obese, will they have to deal with ADHD? Will they have to deal with several comorbidities? Will my daughter develop diabetes, cancer, and cardiovascular diseases at the same time? So we have to think of that. What can we do to change this, or at least help them to tackle those non-communicable diseases so that they can live a good quality of life? They probably will end up with some of them, but maybe not so soon. Maybe when they're 70 or 80, hopefully. But I don't want my grandchildren with diabetes or obesity when they're 5 years of age. I want to make a difference. And if you want to make a difference, go out there and see where you can make that difference. But aligning and integrating your approaches to general health. We don't need to think more. We just need to think differently. Thank you. And as an athlete, I finish on time.
We'll stay up here for a few minutes. So we're going to take about 5 minutes to do some questions and answers from the audience. So thank you very much. It was an enlightening presentation and brings together, I think, a lot of the key concepts that we'll keep revisiting for the rest of the day. So let me take some questions from the audience for Saskia.
Yes, Dr. Green.
John Greenspan, that was a spectacular talk. Not just because of the talk, but because of the enormous leadership. Not just because of the talk, but because of the enormous leadership on your part and on part of PAHO that it reflects. So thank you. So you took us through measures to educate and intervene with the actual target population and the medical dental professions and healthcare educators. Talk to us a little bit about educating key opinion leaders, politicians, and the people who set policy and determine the distribution of resources, because that's still a huge problem.
Should I take a few and then... Yes, thank you, Dr. Greenspan. This is one of the major challenges, and that's where the shift of paradigm has to happen. Because traditionally, as dentists, we tend to take the back seat. We're not at the front. And unless we are able to convince or educate and empower the individuals about the importance of oral health, particularly, policymakers, we want presidents to talk about oral health. President Lula, for example, from Brazil, he was a champion on oral health. And during his terms as president, that's when Brazil made significant changes. We want, football players. As a matter of fact, we're working for World Cup to see if we get some, significant leaders talk about oral health, the importance about oral health. But the message really is not about having nice, aligned, white teeth. But the message really has to be about why it's important, because it relates to general health. Because we have those 3 risk factors, that we share: nutrition, alcohol, tobacco. That affects oral health, and that affects general health. So we have to go even deeper than that. I think we have touched the surface, but we got to go deeper and deeper. So then the message is there. We want, at the end of the day, people to understand that it is important to have good oral health because we have risk factors for diseases that are going to be very expensive for everybody. And I think that is the message. The caries is important, but it is the risk factors that is going to make a big difference. I hope I answered your question.
Another one over here.
Oh, thank you. Working in Malawi, which is a very poor country, things that you are addressing fit the mode of Central America and South America. But in Africa, their diet is very limited. They mainly eat ground white corn, and the kids will chew on sugar cane for energy. And outside of that, there's very little vegetables, no fruit. And how do you approach a community in a rural village, no electricity, with a limited diet?
Thank you. Africa is going to be a major challenge because actually the DMFT for Africa it's not so bad when you looked at it. You know, it's not like the DMFT of a country that is industrialized and with a diet that is based on carcinogenic foods. So one of the challenges that they're going to have is the nutrition transition. This is going to be a major problem because when you look at Africa, when you look at Mexico, their obesity curve happened in a decade. I mean, once those sodas, become part of the normal diet, caries goes way up. So if you were to work at the community level, I think it will be critical, and that will be your message. Caries is important, but nutrition and to begin empowering them that these foods will be coming, and the importance of sugar, that free sugar out there. They're going to have that. So you have to educate them about that. It's unavoidable. That's going to happen. But if you can do some education and work with policymakers, we have a regional advisor for Africa, Dr. Benoit Varenet, who's been working and putting policies for the African countries. He has made very, very significant improvement. We can put you in touch with him so you can perhaps take the same message. But that's going to be one of the biggest challenge, the transition, the nutrition transition. We haven't yet seen it. Some countries, like Nigeria, for example, you see obesity in Nigeria. You see obesity today in Cuba. I mean, the Cubans are getting much fatter, and you see that. And that is the major challenge. I think for dentists, we're just too passive about nutrition. I mean, we're not addressing as aggressive as we should. We should be, integrated with nutrition programs. We should be aligned with their policies. So that's one of the things. It's about empowering. It's about education. A lot of education. Yes?
One more.
Yeah, hi, Art Reingold. I work in the area of immunizations and infectious disease, and as we attempt to try and get people to vaccinate their children, and we actually go to the private sector, like Nestle's and Coca-Cola, to learn how they are so successful at reaching every person on the planet. And when people developed oral rehydration therapy, they recognized that a Coca-Cola bottle was probably the vessel you should use for telling people how to mix oral rehydration therapy, because it was so ubiquitous in the world. What are your strategies for combating or doing battle with what are arguably the most effective advertisers and promoters of ill health in the world?
Great question, and thank you. I'm working, the program of the modules that I show you, that's sponsored by Colgate-Palmolive. And working with the private sector has been an eye-opener for me. And I've sat with the director of marketing because I was curious. Why is it that, Coca-Cola or Colgate are able to reach everybody. He explained to me they have what's called the entry point. It's 3 entry points. And it's your brain, your brain is like a computer, he explained to me, which they show you something and it clicks. They show you again and it clicks, and they show you again and it clicks. Why is it that when you go to the CVS, you want to buy a toothpaste? Where do you go? The red one, the Colgate. Unless you got already your favorite, but mostly it's color. I mean, they're so clever. They use the color. So your brain doesn't recognize really the brand. What your brain is recognizing is a pattern. And that's what Coca-Cola also. And the color red is very clever, believe it or not. When you see bottles of, in several languages, what do you see is that it's the logo, it's the branding. So this is where public health, we need to develop those skills. We need to develop how to do the branding. How are we going to work with the branding for tobacco, for diet, for nutrition? We're very immature in that sense because we don't think that way. That's where the switch of paradigm is going to happen. It's thinking differently, It's looking at things from a different lens. And for us, for the profession, for oral health, we need to develop that branding. And our branding for oral health, as long as I'm at PAHO, which is not a long time, I'm about to retire, but it's going to be the branding, It's going to be, because that's the approach we're going to reach. And our branding has to be through those risk factors. So in vaccines, they have been successful. We have high coverages. And when we propose the introduction of fluoride varnishes into vaccines, it wasn't just by chance. I sat with the director of vaccines at PAHO and the person who was responsible for elimination of polio in the Americas, Dr. Ciro de Quadros. And I asked him, Ciro, if I want oral health to be looked by children and the mother, where do I go? And we sat and worked there, and it was through the vaccine. That's where we were going to, because the vaccine there is a branding about it. Mothers know that they have to vaccinate their children, but that has been a long work. So for NCDs, we have similar, we have a long work. We have a lot of work to do, and it's related mostly to diet. We have to, tackle that much harder and use private sector approaches to it. I hope I answered your question.
Thank you, Dr. Estupian.